Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through hyperlipidemia pharmacology, and we're going to start with a little bit of background of labs and pathophysiology. So let's start with talking about atherosclerosis. I'm not going to get too deep into it. This is pharmacology, but let's understand atherosclerosis is a buildup of plaque in the arterial walls. When we're born, all of our blood vessels, and we're talking specifically arteries right now, are soft and pliable. They can bend, they can flex, they can be pushed around, they can constrict and dilate. All of that is normal pathology. However, physiology, I'm sorry, as we get older and as we have poor lifestyle habits, our arteries basically naturally get a development of plaque. So plaque is a buildup on the inside of the arteries and it becomes hardened. It's a buildup of cholesterol and other substances, primarily cholesterol. And as this builds up inside our arteries, as you can imagine, our arteries are no longer soft and flexible and pliable. They're no longer dilate and constrict like they used to because they have this big hardened gunk built up on the inside of the vessels. What does this cause? This causes a few things. It causes increased risk of heart attacks, strokes, and pulmonary artery disease. Again, these are all issues of clots that come from plaque. We talked in another lecture when we had our angina lecture. We talked about discussing MIs. We talked about how the most common pathophysiology of an MI is where a piece of plaque, and this is what we're talking about, a piece of plaque, a piece of cholesterol that's been sitting on your arteries since McDonald's in the second grade is now going to go ahead and break off, and now it's going to end up causing an obstruction. Also keep in mind, it doesn't necessarily have to be a piece of plaque that breaks off. When we talk about atherosclerosis and a buildup of plaque, this plaque makes the artery itself smaller and smaller and smaller on the inside because the plaque has taken up more and more space. Eventually, the plaque buildup itself can cause the whole artery, the lumen, the opening inside the artery, to get smaller and smaller, which can cause an obstruction of blood flow, very obviously. So when we talk about cholesterol, we're talking about avoiding atherosclerosis or dealing with atherosclerosis. This is not to be confused with arteriosclerosis, which is more associated with hypertension. So let's talk about labs for a minute. When we talk about cholesterol, we're always going to talk about a lipid panel. A lipid panel is going to have four primary numbers on it: your total cholesterol, your triglycerides, your HDL, and your LDL. Now, the correct numbers should be on here. Your total should be under 200, your triglycerides under 150, LDL under 100, and your HDL should be over 50 in females or over 40 in males. Now, a few things to point out. First of all, LDL is what we target. When I say target, when a patient is being treated for cholesterol, we're constantly reassessing the lipid panel, but the LDL is the number we're focused on. And when we talk to patients and we give them goals, we say, hey, I'm going to put you on Lipitor, atorvastatin, 20 milligrams, and I'm going to see you back in 90 days. I'm hoping that in 90 days, your LDL, which is right now 139, is down to 99. When we give the patient numerical goals for cholesterol, it's always associated with the LDL. When we're treating a patient for hyperlipidemia, high cholesterol, and also you may hear the term hypercholesterolemia, or you may hear the term dyslipidemia, we're going to use all of those interchangeably. They're all a problem with your cholesterol. That is distinct from a separate problem, which we'll talk about in a few minutes, of hypertriglyceridemia. Let's move on. First line treatment, before we even get to medications, can be lifestyle modifications. And since you're watching our cardiology pharmacology series, we've talked about this over and over again. So this is where we want to decrease saturated fats and cholesterol out of their diet. We want to increase fiber because fiber has been shown to improve patients' cholesterol. We want to get them exercising more and lowering their weight if appropriate. We want to get them quit smoking if they need to. And if they have diabetes or hypertension, we definitely want to get those under control. One thing I do want to point out, hypertriglyceridemia, where the triglyceride is extremely elevated, is most commonly associated with uncontrolled hypertension. So if you see a patient that has a lipid panel and their cholesterol numbers are not great, but their triglycerides are through the roof, almost always that's going to be uncontrolled hypertension, or it'll be isolated hypertriglyceridemia. But the first thing, because of the most common cause, the first thing we're going to do in those cases is manage the patient's diabetes, especially if they haven't been diagnosed with diabetes. We definitely need to do the testing and find out, confirm that diagnosis, and start treating it. When we are treating a patient with statins or any medication for cholesterol, very often the decision is based on an ASCVD. An ASCVD is atherosclerotic cardiovascular disease risk calculator. And basically, we put in a bunch of information. This only works for patients over 40. We put in a bunch of information: their blood pressure, their cholesterol numbers, their age, their gender, whether they're a smoker, whether they're diabetic. And it's going to tell us statistically, based on millions of data points, statistically, what are the odds of this person having a cardioembolic event, meaning a heart attack or a stroke, in the next 10 years? And this is on very solid evidence, on very solid statistics. And we do use this tool extensively in our decision about whether or not to put a patient on statin and even at how much. I do encourage you to go play around with it. If you're looking online, you can Google MD Calc ASCVD. It'll pop right up. And you can play around with it. And you'll see, based on the patient's information, it can tell you that the patient should be on a low dose statin or a medium dose statin or a high dose statin. Even further, I use this when I show this to patients. I'll plug in the numbers and I'll show them, hey, look at our risk of getting a heart attack or a stroke in the next 10 years versus if you quit smoking and I change that parameter to a non-smoker, now look how much your numbers drop. So we can use this as a good tool to help educate our patients, to help get them on board with our non-pharmacological interventions, because this is something that we really want them on board with that. Plus, this is something that they can really see statistically how much of an impact, a positive impact it would have when they adopt these healthy lifestyle modifications. If we are going to be treating cholesterol pharmacologically, we always start with our first line drug class, which are the statins. The official name for them are the HMG-CoA reductase inhibitors, but they're more commonly known as statin. There's a whole bunch of drugs in this class. There's atorvastatin, rosuvastatin, simvastatin, irvastatin. There's a whole bunch of them. They all end in statin. So finally, a drug class that's actually easy for nursing students. Some of these are very commonly known, very well marketed on TV, Lipitor, Crestor, things like that. These medications work exactly the way it sounds. HMG-CoA reductase inhibitor inhibits HMG-CoA reductase. HMG-CoA reductase is responsible for an increase in LDL, that's the bad cholesterol. By inhibiting that, I get a decrease in LDL, so a decrease in your cholesterol. Some of these medications you may be told to recommend to the patient to take it at night. That doesn't really apply with atorvastatin and rosuvastatin. The reason we take it at night is because that's when most of the cholesterol synthesis, the development of cholesterol occurs. However, atorvastatin and rosuvastatin are considered the most powerful statins, and they can work by day or night. However, simvastatin and all the others are recommended to be taken by nighttime because we want the medication to have its peak effect during the same time as the peak effect of building cholesterol in the body, which makes perfect sense. What do we use these drugs for? We use it for hyperlipidemia and the prevention of cardiovascular disease. So those are your two indications. So yes, you can have a patient taking this with a perfectly normal cholesterol level, and they got put on it because they had some other risk factor. Presumably they had a previous heart attack or embolic stroke. I do want to point out a few things. First of all, when we put a patient on medication for cholesterol, let's start with this. Almost always it's going to be for the rest of their life. What do I mean by that? Well, two things, and you could tell this to your patients. Number one is we're going to do this until we get the patient's cholesterol level down. But once we get the patient's cholesterol level down, let's say their LDL was at 180, we got them on 40 milligrams of atorvastatin, and 6 months later, their LDL is now 80. Perfect. However, it's because of the medication that they're down to 80. So we're going to keep them on that medication. Now, if their numbers start to drop even further because they're doing really good diet, exercise, things like that, then we could try to taper them off the drug and see if that LDL stays under 100. If it does, by all means, we can get them off of it. In real life, that's uncommon. It's less than 10% of all patients that go on a statin that are able to successfully come off of it and maintain their LDL below 100. You can educate your patients about this, that yes, this doesn't necessarily have to be for the rest of your life, but statistically speaking, it will be. And that's not a bad thing. It shows in study after study that it increases your chance of survival. So why wouldn't you want to make sure that your LDL stays at below 100, whether it's with medication or without medication? Next, I do want to talk about pregnancy because this medication used to be considered a category X under the old FDA criteria. It used to be 100% teratogenic. Nowadays, FDA changed its recommendation in 2021, and now it says that the provider and the patient should consider the risk versus benefit in continuing it during pregnancy. What do I mean by that? At the end of the day, if a patient is on a cholesterol medication and they become pregnant, meaning that they were young and of childbearing age and they were already on a statin, it's usually a pretty bad sign for their heart health. And in a lot of those cases, we're actually going to continue the medication because if the patient was already on it at that age, they're probably not in the best heart health. So we probably want to keep them on that. But again, that's an individualized decision. I'm not even qualified to make that. That would be a cardiologist that would make that decision, or the OBGYN that would make that decision about whether or not to continue it. But just want you to know, some of the older textbook will still stay teratogenic, but as of 2021, the FDA said it's not officially teratogenic. It is harmful, but it's a risk versus benefit because there's also tremendous harm in taking someone off of their statin. I do want to also emphasize that point. Once a patient gets put on a statin, not only do we need to make sure that we keep their LDL levels low, whether it's through the statin or through other means. But also keep in mind, we are generally cautious about taking that away from a patient because once they've had that benefit, it's not always the best idea to get the patient off of it. So we covered pregnancy, and we also covered this the first line. This medication should be avoided with grapefruit juice. I don't usually include those in these slides because that can be said about half of all drugs. I'm not going to cover for each and every one. Most of you are probably familiar with on pharmacology tests. We're very often asked that. And almost always the question is, yes, you should avoid grapefruit juice with the different medication. The only reason I mention it here is because this is the #1 most prescribed medication in the United States, most prescribed drug class in the United States, period. It is the #1. If you're waiting until we're going to get there, today's the day. There are a lot of other #1 drug class or in the top 10 drug classes, like the SSRIs are in there, the beta blockers are in there, the ACEs and ARBs are in there. However, this one is the first line agent as opposed to blood pressure. If you already watched that lecture, we know that there's a bunch of different first line drugs. For cholesterol, this is the first line drug. Therefore, tens of millions of people are on it. So this is something that is considered a very tested on drug class. I wanted to specifically throw in to avoid grapefruit juice with this medication. If a test would take it a step further, which I don't think it would at the RN level, this medication would actually interact with grapefruit juice by increasing the effects, but that's not necessarily a good thing. Moving on and talking about statins, we have side effects of hepatotoxicity, so we definitely want to monitor their AST and ALT. We also want to monitor anytime you see hepatotoxicity, you're going to reassess your patient for right upper quadrant pain or jaundice, things like that. It can also cause myopathy, which is almost always the reason we would stop a patient from taking this medication. If it asks you what's the most common reason to discontinue a statin, it would be because of myopathy. That's where the patient develops muscle aches and pains, which then we get concerned that it's going to lead to rhabdomyolysis, which is a breakdown of muscle, which goes through the kidneys and destroys the kidneys. So that's hepatotoxicity, that's myopathy, and that's rhabdo. HMG-CoA reductase inhibitors, the statins come in low dose, medium dose, and high dose. Only 2 of them can go up to high dose. That's atorvastatin or rosuvastatin. I think that's pretty beyond what an RN level would test you on, but just an FYI. Because so many patients are on these drugs, this is definitely a drug class that you want to know about, especially for the NCLEX and things like that. And there is a whole lot to know about these. When we put a patient on a maximum dose of a statin, we can get their LDL cut in half. So if they come in with an LDL of 195, one maximum dose statin can get them down all the way down to below 100. I do want to throw a few more bits of information out here before we move on from statins. First of all, if a patient has diabetes or previous coronary artery disease, then the LDL, we would actually move the target to under 70. We want that patient to have an LDL under 70, not just under 100. I also want to point out that if a patient has an extremely high triglycerides, I think most labs, anything over 400 or 500, then the lab will be unable to calculate what their LDL is. So very often we'll have to get the patient's triglycerides under control in order to know, at least based on standard testing, even what their LDL is, but obviously we can assume it's high at that point. Next drug class we have are the bile acid sequestrants. We don't use these a whole lot. These are alternative options. These would never be the first line drug. And these work by increasing the loss of LDL through the GI system. It helps the GI system get rid of it through bowel movements. What do we use this for? For hyperlipidemia. This one is not used for prevention like the statins were. This one, obviously, because it works through the GI system, it can cause GI effects such as constipation. And this should not be taken with any other medications. So take this an hour before or 2 or 3 hours after any other food. You've probably seen this education with antacids also, that you should take an hour before, 2 hours after any other meal. Again, I don't have a ton to cover about this. It's not like the statins. It's such a universal drug. Next, we have the cholesterol absorption inhibitors. This is ezetimibe or Zetia. This is more common than the last one, than the bile acid sequestrants, and these work by inhibiting absorption of cholesterol, so it blocks the body from absorbing cholesterol. This is used for hyperlipidemia, and this one can be used like the statins, although off-label, again, for that prevention of cardiovascular disease, because obviously we're big into preventing cardiovascular disease. Again, this has similar adverse effects of the statins, the liver issues, specifically hepatitis in this case, and again, the myopathy, though not nearly as prevalent as it is with statins. This is mostly used as an add-on for a statin, meaning if a patient has a cholesterol LDL of 250 and we need to get them down to 100, even maximum dose Lipitor, atorvastatin, is not going to make that happen. Versus if I put the patient on the atorvastatin and add on ezetimibe, then the two together can get them down that much. So it's used a lot as an add-on medication. The other time it's used is where, as an alternative agent, like we already mentioned, statins are first line, everything else would come second. This one also has that it's not recommended in pregnancy. And again, it's that decision between the provider and the patient. The next drug class we have are fibrates. So fibrates have a different indication here. These are not for hyperlipidemia. These are for hypertriglyceridemia. Remember we said in the beginning of class, or the beginning of this lecture, I'm sorry, that triglycerides are very often elevated. Most common cause is uncontrolled diabetes. And the second most common cause is isolated hypertriglyceridemia, which is what this is talking about, where they don't have uncontrolled diabetes, but their cholesterol's off, specifically their triglycerides. In that case, we give them fibrates. Fibrates specifically lowers the VLDL, very low density lipoprotein, and that is the triglycerides. This again has the same thing of the myopathy, the hepatotoxicity. Again, don't forget that myopathy means muscle aches and pains leading to breakdown. And this one also can cause an increased risk of gallstones. So be very careful giving this to a patient with a history of that. This is, again, not necessarily going to be a first-line agent, and this is going to be focused on the VLDL. Now, statins will also lower your triglycerides, but this one will focus on your triglycerides. So I wanted to be clear about that. And then finally, we have the PCSK9 inhibitors. This class of drugs has been around 10 or 15 years or so. And this has become our go-to second agent after statins in most cases, especially cases where the patient has a high LDL. When a patient can't tolerate statin, this would be our next option, if feasible. And I say if feasible because this is a monoclonal antibody. So if you've learned monoclonal antibodies in one of our other lectures, and we've discussed it multiple times, this is the drug. They're parenterally only. They're by injection, meaning they're by injection. They're very expensive. They take several months to work. They depress your immune systems. There's a whole lot of issues that go along with it, especially in most cases, unfortunately, the fact that they're very expensive. However, if all those boxes are checked and the patient's able to take it, this does become our next line agent in many cases if a statin's not working. So what are the drugs over here? Alirocumab or evolocumab, that's Priliant and Repatha are the two brand names. These work by preventing the breakdown of LDL receptors so that there's more LDL receptors to process and get rid of LDL. What do we use this for? Again, hyperlipidemia and prevention of cardiovascular disease, exact same two indications as statins, because we use this exactly the same as statins, other than that statins are first, this would be second. And this, okay, and then it's given by subcutaneous injection. I already said that. It's dosed every 2 weeks. I already mentioned that it's dosed parenterally, not on a daily basis. We already mentioned in the beginning of class, I'm just going to repeat it again. The goal of therapy is to reduce the LDLs. And finally, the last note I'm going to make is that niacin is a drug that's in some of the older textbooks for hyperlipidemia. However, it is not in the current guidelines. I wouldn't expect that to be on the NCLEX. Here are the references. If you have any questions, please reach out. Have a great day.